Assalamu alaikum. Thank you very much for the invitation. It's really a pleasure to be here and a pleasure to be talking about a topic which for most cardiologists we would say not my problem, but hopefully by the end of this session you will say that, or you'll see that we're probably an integral part of the solution. I have no financial disclosures, but I will also tell you that talking about PE would probably be better by a thrombosis specialist, a hematologist, or a pulmonologist. But I'm going to give you a cardiologist's perspective, and hopefully you will, I'm trying to raise awareness. As you know, acute pulmonary embolism is quite common. It has an annual incidence of about 1 in 1,000, and it is the third cause of cardiovascular mortality following MI and stroke. And drawing from our cardiology literature, we've done very well in managing myocardial infarction, whether it's STEMI and non-STEMI after the advent of PCI. So when you look at the mortality of MI in 1995 and 2005, you'll see that the mortality was reduced from over 15% to less than 5%, even for ST elevation MI. However, when you look at mortality of acute pulmonary embolism, on the left you'll see in 2002, and then on the right, the PERT registry, which is a multiple centers, large centers that manage PE and have registry, you will see that the mortality is on average about 10%, which when you compare it to MI is quite high, and that's a 1-month mortality, and then a 1-year mortality is even higher. It's not surprising that there's more mortality after because they're sicker patients, they have malignancies or other comorbidities, but still, if you compare that to, like for us as cardiologists, these are striking numbers. This is the current management or guideline recommended management. So anticoagulation is the cornerstone once the acute PE is diagnosed. Unless there's an absolute contraindication, then it's IVC filter insertion. And then it's risk stratification. And I believe that risk stratification in acute PE is the most difficult part in managing these patients. So if patients are stable, then you look for clinical parameters or risk factors, which we call the PE severity index is the most commonly used score, or PESI score, or the simplified PESI score. If there are no clinical parameters that are concerning, these are low-risk PEs. Fortunately, about half of the patients that present are low-risk PEs. You give them anticoagulants and you can send them home. However, if you have any of the risk factors, you can, focusing on the right column there, you'll see that if you have any of these points, your mortality goes from 1% to 11%. And we really are, I mean, as cardiologists, we have no awareness of how to use these risk scores, but I should tell you that any of these really raises your risk. And once you have any of the clinical parameters, now you're in the intermediate risk range. The next step in stratification is looking at the RV dysfunction. Look whether on CT or transthoracic echo and cardiac enzymes. If you have both, then this is an intermediate high-risk PE, and if you have one or none, then this is an intermediate low-risk PE. But the treatment remains the same. It is only anticoagulation. And the reason for that is, this is a landmark trial in PE. It was done about 10 years ago. It's called the PYTHO trial. It's about 1,000 patients, and by PE data number, this was a huge trial. They gave thrombolytics to intermediate risk PEs, and there was a significant improvement in mortality and prevention of hemodynamic deterioration. However, it came at a very heavy price, where the extracranial bleeding was 6 times more, and the intracranial bleeding was 10 times more. So the number needed to harm was really high. And based on that, the guidelines do not recommend using thrombolytics, and it's a class 3 indication for intermediate risk PE. Tells you that if you reduce the clot burden, there is better outcome, but because of the price that you have to pay with lytics, it is class 3. Unless there is hemodynamic deterioration after, where you go for rescue thrombolysis, this is class 1, or class 2A is surgical embolectomy or catheter-directed treatments. One thing in the PYTHO trial is that in patients that went for rescue systemic thrombolysis, there were about 23 patients, 16 of them died. So once you reach that hemodynamic deterioration, the situation is actually quite precarious and the outcomes are not very good. Intermediate risk PE is about 1/3 of patients that are presented to PE, so a significant number of patients. And then this is relatively easy that if you have a hemodynamically unstable patient, then the options are limited and you should give systemic thrombolysis unless there's a contraindication, which is actually quite common. Then the next step, class 1, is surgical embolectomy, and then class 2A is catheter-directed treatment. And that's how it is now in the current guidelines. Talking quickly about surgical embolectomy, because we have some surgical colleagues, the first successful surgical embolectomy was performed even before bypass, which was 1924, 100 years ago. And the mortality has improved or has been reduced over the past few years compared before 2000 and after 2000. It's commonly used nowadays with ECMO, but the outcome is really dependent on the clinical status of the patient before going for the surgical embolectomy. We usually resort to surgical embolectomy when the patients are sick and deteriorating, and some people argue that you should tackle this before the deterioration. This is the so-called PE death spiral, and the cause of death is right ventricular failure. Some argue that because of that, it is a cardiac disease. A very important concept, and this has been coming repeatedly, is the normotensive shock. In patients with intermediate risk, they look good, they're relatively young, you talk to them, they talk to you, at rest, they look fine, but as soon as they walk or go to the bathroom, their heart goes up, they're tachypnic, and we have difficulty, or other colleagues have difficulty evaluating that shock or subclinical shock. And this occurs in 35 to 40% of patients with intermediate risk PE. And it's quite common, if you can see the bottom line, if you have positive troponins, elevated BNP, severe RV dysfunction, saddle PEs, concomitant DVTs. So when you evaluate or risk stratify patients, you have to really identify those patients because they're the ones that are more likely to go on to hemodynamic deterioration. So we give anticoagulation to everybody, but of course it has limitations. So it really depends on where you are in that spectrum or spiral. Anticoagulation relies on the patient's ability to autolyse. So it's not a lytic, it just prevents coagulation, so it relies on the autolysis. And the RV must sustain the afterload for a period of time. So if you're early on, there's an increased afterload, RV dilatation, you probably can get away with just anticoagulation. However, if the RV contractility starts to go down, perhaps you should consider reducing clot burden. And certainly if the cardiac output starts going down, then you should reduce it as soon as possible and or consider supports such as ECMO. If you reach low cardiac output, then you're at the high risk category now. There's hemodynamic deterioration and you have to give thrombolytics. But thrombolytics on their own come with a very excessive risk of bleeding, as was mentioned, over 9% of major bleeding and 1.5% of intracranial bleeding. Already on patients presenting with acute or high-risk PE, about 30% of them have absolute contraindications to lysis. And in all patients presenting, lysis is only given less than 30% of the time, even in major centers. And despite all our efforts, the mortality of high-risk PE is still around 30%, which is actually the same as described in 1974. So, other things that we know, and you might have faced, is that when we give thrombolytics and put patients on ECMO, the outcome is bad. When we give thrombolytics and after initiation of CPR, the outcome is bad. And when we give thrombolytics and we send them for surgical embolectomy, the outcome is bad. So not only that, but also when patients present, you don't know where they are or how long has it been since that clot has formed. We know that clots organize, and the earlier RBC-rich, less fibrin, you probably can give them lytics and will be very effective. Later on, 2 weeks later, if the patients present 2 weeks later, it's more organized, more fibrous, so all you get is the side effects and none of the benefits. And up to now, we don't really have a test to allow us to detect that. I'll just brush on ECMO, and I don't know if you saw PEs, you probably saw patients on ECMO. Most of the time, ECMO is given in eCPR, but ECMO in patients that didn't deteriorate very much has beneficial effects. So it does allow complete cardiac support. It offloads the RV and causes decompression. It allows perfusion to organs. Patients are anticoagulated throughout, and then gives you time to decide on what to do next. So This is some data from Belgium. It's a retrospective data that shows you that if ECMO was given alone before you have to give thrombolytics, the survival is close to 90%. However, if a fibrinolytic was given, then that drops to 35%. So when you give a lytic, you have to really be sure that patients hopefully would be a low-risk candidate for bleeding or side effects. Moving on. So I just would like to acknowledge some of the research that has been done in the Gulf. On the left, you see this is from the Eastern Province of Saudi Arabia, a single center experience, where they looked at 92 patients presented with PE and did a thorough evaluation. Their mortality of all these patients diagnosed with PE was reported as 15%. About 20% of them were post-operative. And on the right is a nice study as well from Oman of over 400 patients, showing that the mortality related to PE was also in the range of 15%, and about a quarter of them were post-op. So you'll see common PE scenarios like this. Patients are post-operative, patients had recent stroke, patients have recent trauma, pregnancy, elderly, cardiac arrest. So what do you do for these patients with the limited options that you have? So multiple challenges are there. One is that acute PE also straddles multiple specialties. We as cardiologists don't get involved until it's late sometimes, and there's not much going on. So that's why there's a call for a need of a response team. Hopefully Dr. Ben Musa will let us know about it more. The presentation is heterogeneous, it's dynamic. So optimal evaluation and risk stratification is key. And again, that's where the team comes in. There are limited therapeutic options up to really recently, so we need to innovate, or there was a need for innovation in these alternative treatments. Hopefully Dr. Abdullah Ismail will talk to us about that. And then it's not without long-term sequelae, such as chronic thromboembolic pulmonary disease or chronic thromboembolic pulmonary hypertension, which Dr. Khudair, inshallah, will talk to us about. And I will stop here and thank you very much.